Thank you very much. I'll first share my screen. Okay, can you see my screen?
Yes.
Yes? Yeah, okay, thank you. So thank you very much. I'm going to give you a very brief introduction to set the scene for Professor Ferraris and Professor Zschocke. But I would just like to introduce you into the topic of Ehlers-Danlos syndrome. So the Ehlers-Danlos syndromes have been described for a long time. And before there was a molecular or clinical diagnosis of Ehlers-Danlos syndrome, people affected by, presumably affected by this disorder, were present on fairgrounds and circuses because they had a very remarkable possibility to stretch their skin, such as the elastic skin man and the India rubber man, or the elastic lady that you can see here on these some of the first pictures of people with Ehlers-Danlos syndrome, or by their remarkable ability to bend their joints, such as the human pretzel depicted here. So, but what are the Ehlers-Danlos syndromes? So the Ehlers-Danlos syndromes are a group of disorders that are quite heterogeneous, both at the clinical and the genetic level. And so these are heritable connective tissue disorders, and all of them are characterized by a variable degree of skin hyperextensibility and fragility, usually also generalized to joint hypermobility, although the joint hypermobility can also be more localized to a few joints, and then variable signs of generalized tissue friability. So the Ehlers-Danlos syndromes are actually multisystemic disorders that can almost affect virtually every organ or tissue in our body. So it can be associated with craniofacial abnormalities and dental abnormalities, can be accompanied by ophthalmological problems, joint hypermobility, and a lot of associated musculoskeletal problems. And just to name a few, we can see scoliosis, we can see pectus deformities, we can see joint dislocations, congenital hip dislocation, etc. And then, of course, the skin is affected as one of the hallmarks of EDS, with a soft and hyperextensible skin, usually also quite a thin skin with that bruises and that also has very easily has wounds, and with also delayed wound healing and the formation of thin atrophic scars. And then we can also see friability and fragility of the internal organs, with, for instance, prolapses of internal organs. And then in some subtypes, but not in all, you can also see quite a remarkable vascular fragility, sometimes even with the risk of vascular ruptures. Like I have already said, the Ehlers-Danlos syndromes are a group of disorders, and there have been many attempts at classifying these disorders. And so currently, the International EDS classification recognizes, well, 13 subtypes, but actually a 14th was identified after the publication of this classification in 2017, with mutations being found in, at present, 20 different genes. So why is molecular diagnosis of Ehlers-Danlos syndrome important? Well, first of all, it's very important to enable accurate genetic counseling. As you probably will see in the following presentations by my colleagues, there is sometimes a lot of overlap between the different subtypes clinically, and it's not always easy to make the correct clinical diagnosis. So molecular confirmation is very important because it will confirm the transmission pattern and will allow us to have an accurate estimation of the inheritance risk for future children or other family members, for instance. for the more severe types of Ehlers-Danlos syndrome, it's identifying the underlying mutation also opens the way to prenatal diagnosis and pre-implantation genetic diagnosis. It allows us to formulate more accurate and personalized guidelines for the follow-up and management of the disorder in a particular family. And then it will also be important for research because it allows us to better classify patients within the same subgroups of EDS, which allows us to define or do natural history studies to define genotype-phenotype correlations. And then also, hopefully for future clinical studies, it allows us to stratify the patients in the same subgroups. And with this, I would like to give over to Professor Zschocke, who will talk about molecular diagnosis for the Ehlers-Danlos syndromes. And I will stop sharing my screen.
Right. So I hope you can see my screen and the slide. I see a nod from Franziska. Hello from me as well. And I've been given the task of talking about strategies and pitfalls in the molecular diagnosis of the Ehlers-Danlos syndromes. And what I will talk about is actually probably relevant not just for the EDS, but also for other conditions. So I'd like to start with a few general aspects. Genetic diagnosis is actually not just to read the constellation of the genetic text in the individual genome, but really the essence of genetic diagnosis is trying to make the connection between our genome and ourselves, to try to understand from the variants that we find in our genome explanations for problems that we have and maybe also get information on possible treatment strategies. Obviously, this is a long stretch and there are other non-genetic factors involved in this connection. And we need to make sure that we understand that this is a causal link starting from the genetic information in a protein coding gene. The first really is that this influences the production and processing of molecules and cellular functions. That in turn has influence on our organ function and structure, which can be assessed with various standard medical means. And finally, this obviously reflects what we experience ourselves in our clinical symptoms and signs. So all these three levels are phenotype levels, and genetic tests is actually any type of investigation that allows us to look at this connection. So a clinical investigation that identifies a clear diagnosis of classical Ehlers-Danlos syndrome is in fact a genetic test, if you would like to put it, because we identify a genetic condition. Or a biochemical test in newborn screening is a genetic test if it leads to the diagnosis of phenylketonuria. The question always is, do we understand this connection? And the main challenge in genetic diagnosis is to be sure that what we read in the genome, which is relatively easy nowadays, if you understand it, whether this information actually explains what we see in our patient. And there are a lot of pitfalls that one needs to understand. One example that shows that it's not just easy to look at a gene and then find a variant and say, okay, that means this disease, comes from other collagen diseases. Obviously, several Ehlers-Danlos syndrome forms are caused by mutations, variants in collagen genes, and the most typical and most relevant collagen is collagen 1, which is affected in osteogenesis imperfecta or brittle bone disease. It's the main collagen in humans, and I would like to talk a little bit about this because there is something paradigmatic that we can learn from the mutation, from the pathogenic variants in the collagen genes. There are actually two different precursor genes, COL1A1 and COL1A2, that together form proteins that are arranged as triple helix structures, which then are cross-linked to form the collagen network in the human body. And there are different types of osteogenesis imperfecta caused by pathogenic variants in collagen 1. Type 1 osteogenesis imperfecta is a kind of milder form. Affected individuals are have slender, long bones, have normal stature, and experience fractures of the bones without adequate trauma. They have no deformities in the skeleton usually. The sclera may be a little bit blue because they are translucent a little bit. Teeth are normal, and sometimes you got hematomas. So that's osteogenesis imperfecta type 1. Osteogenesis imperfecta type 2, the severe perinatal lethal form, has fractures even before onset of birth in the womb, can be very severe. This is a babygram X-ray from a child with osteogenesis imperfecta type 2. There are fractures of the ribs, and the children usually die before or during birth. Also after birth, the fractures of the ribs interfere with normal movement of the thorax so that they can't survive. Why do I talk about this? Because there are two paradigmatic types of mutations of pathogenic variants in the COL1A1 or 2 genes. There are null mutations which completely remove the protein, and there are missense mutations which cause stable proteins which are still there in the cell. So the question that I like to ask at this place is, which mutation type is usually found in which type of osteogenesis imperfecta? And if this wasn't a webinar, I would let you raise your hand or do it online. And usually the majority of the listeners would say, well, that's a severe mutation, so that must cause a severe form, and the missense mutations cause a mild form because there are some stable proteins left. And I ask this because it is the other way around, obviously. And I would like to explain this because that's also relevant for the EDS forms. If you have a null variant that removes a protein, you have reduced normal protein. You can build normal pro-collagen and a normal collagen network, which is not as strong as it should be. But it only causes a mild form of osteogenesis imperfecta. If you have a missense variant that leads to a deformed protein which you don't get rid of, and that is included in the collagen assembly, that interferes in a dominant negative fashion with collagen production and causes the lethal severe form. So you need to understand this concept that different variants in the same gene can cause very different conditions and severities, and that's also true for the EDS syndromes. All the different monogenic types, that is all except of the hypermobile EDS, are caused by variants in single genes. And this means we can diagnose them on a genetic level with molecular genetic techniques. There is a number of techniques available for genetic analysis. I would only talk about three very briefly because that's what you would normally use. Traditionally, the gold standard of sequence analysis was Sanger sequencing, which you probably all know. You amplify your target region in the genome, a few hundred nucleotides out of 3 billion, and then undergo a sequencing reaction where you create segments that are sequence based in their length and have a fluorescent label indicating a particular nucleotide, and then you separate it on a sequencer, and you can read in the form of these different colors the sequences of the PCR product. That was for several decades the main way to actually diagnose genetic monogenic diseases, the majority of monogenic diseases, but it's relatively work intensive. You have to do a PCR amplification. You still have an error rate. You do not find the variants that are outside your PCR product. And you do not have a quantitative analysis. This is still used in some places today, but we wouldn't use this anymore as our primary diagnostic method. Another now 20-year-old method is analyzing the quantity in a certain gene or a certain region of the genome. We all have 2 copies of most of our genes, and if one copy is missing, you do not recognize this normally by a standard PCR analysis, so you need special methods. The one which is still widely used is the multiplex ligation dependent probe amplification, or MLPA. So this is necessary when you do Sanger sequencing, to do this as well, to have a quantitative result. We have changed in our institute, we have changed the method for standard genetic analysis to massive parallel sequencing, or what's called next generation sequencing, even though it's the kind of previous generation sequencing nowadays, because there are other generations already available. We like to call it massive parallel sequencing, and I'd like to talk a little bit about this with you, because that's what one should really do when one thinks of EDS. These are the steps that are involved. We need to prepare the sample, do the sequencing reaction, align the reads that we generate with the reference sequence, identify variants, and then have to spend time on the functional and clinical interpretation of the results. So how does this work? You take genomic DNA or other DNA, you fragment it into small pieces, and then you probably like to enrich what you're interested in, maybe selected genes or certain regions of the genome. Quite often nowadays, we would look at all coding genes in the genome, the so-called exome, but you can also enrich for transcripts. Why would you do this? Because for a full genome analysis with more than 3 billion nucleotides, you need large instruments and a good amount of bioinformatics. So it's more cost effective to enrich what you're interested in, maybe as an exome, which is our standard approach in our institute in the moment. Okay, so you have your fragments that you would like to get sequenced, and then you add adapters and you align them onto a slide where you form clusters by local amplification in these kind of tree-like structures. And then you can read this under and a video camera. You include a nucleotide, you look at that and it sees a green dot, and then on the slide, on the image of the video, you can see a little green dot indicating a T. Then you wash it off, take the next slide, there is a G, and so on. And in this method, you can actually sequence these piles of these clusters of copies of a primary target structure that was aligned to the slide. And from the colors that you have stepwise on the slide, you can read the sequence of one fragment. And you do this massive parallel. So you have millions of reads like this. The next thing is to align them to the reference sequence. They're from the human genome, so they should link to what we know about the human genome. And when you do this, you have many single reads covering the same region. And then you see here that in one spot, about half of the reads have a different nucleotide compared to the reference. So instead of a T, which is normal, you have a C. So that would be a heterozygous variant at this position. And it's pretty safe because you have many reads that give you the same information. There are also some reads which have kind of open or wrong nucleotides, but that's the way it is, and you exclude them because they are probably just chance mistakes. The next step is to look at all your reads and then look at your variants in a automatically generated variant list, which you follow certain filters, and the way you set those filters influences what you identify or what you miss. Sometimes if you have only a few reads and you have very few variant reads, then you may miss it if the criteria are set too tight. And then you look at that from maybe from genes that you know that are relevant or from clinical terms, or maybe you look at all variants that are known to be disease causing. There are different approaches. You should also not just trust the computer. We feel very strongly that you should have a good suspicion and should say, okay, I believe this is a classical Ehlers-Danlos syndrome, so we should have a variant in those genes and look at them in more detail, because sometimes you find in the raw data changes that are disease causing, but they are not called in the variant list that the computer generates. For example, not everyone looks at the quantity. The number of reads on one position reflect how much template, how much DNA on this position was there. And with good methods, good bioinformatic methods, you can see that, for example, here in a patient, 3 exons, that was in this case a breast cancer gene, have the total number of reads is lower than you would normally have compared to other exons. And you analyze it with different softwares, and you see this is a heterozygous deletion, or when it's increased is a duplication. That is very important that the lab does this, because if you miss a deletion or a duplication, and I'll talk about that later a little bit, you miss the disease-causing variant. Another example is depicted here, again from a BRCA analysis. We had no pathogenic variant in our variant calling file. We had no deletion or duplication, but we thought, let's look at the raw data. And when you compare the patient raw data, that is the number of reads from kind of the higher, the more reads in our patient and our control, you can see that here there is a funny break. There is something like a cliff going down. If you zoom into this, there are a good number of reads that seem to stop immediately, all on the same place. And when you look in more detail, you see this actually is not the end of the read, but there is some other sequences which the computer couldn't align. That was an insertion of a few hundred nucleotides into exon 3 of the BRCA2 gene, which would not have been recognized by the computer at the time, but required careful examination of the raw data. And that was obviously a disease-causing mutation in heterozygous state in half of the in one of the 2 copies of the gene. So when you do an exome, and we would normally do exome for all indications nowadays, but we only look at the single genes in question, you get a lot of variants. These are old data, but we can expect that several 10,000 variants will be found in each of us that are not like the reference sequence. Many of them are functionally irrelevant, but for example, here, if you combine the novel and the non-novel variants at the time, you had 100 variants that cause termination of the basically of the translation, a stop codon, a nonsense variant, which is expected in most cases to destroy the meaning of the gene. 100 of them in a normal control person. And we all have these. And so it's a question, what do we do? How do we interpret these data? And that's why we need to, number one, narrow down our focus onto genes that are relevant, and then try to interpret the variants that we see there. One important aspect is how frequent is the variant in the general population. There are good databases now available for many populations in the world. If it's common, then you would, for example, it's more than 1 in 1,000, you would not expect this to be a dominant disease, for example. Or you assess, you predict the functional biological effect, both on protein or splicing level. You look, is it conserved in different species? You look at databases. Is it, has it been reported before? Maybe also in the literature. If you're still unsure, you may actually look at co-segregation of a disease in a family. Is it a de novo variant that is present in a person who is the first one in the family who has a disease? And maybe even you do expression of functional analysis at the end. In any case, the result is a classification in where we make a decision on how we assess the functional clinical relevance. Is it either certainly non-relevant or certainly pathogenic, or likely non-pathogenic or pathogenic, or are we not sure? We are quite often, we must say, we are uncertain because we cannot be certain unless more people with the same disease have a new variant. And these are problematic, these variants of uncertain significance, because we cannot use them for predictive testing. Just for entertainment, a variant that looks like it means nothing, but was disease causing, just to kind of illustrate the complexity from another a disease called Cold-Shiller-Tön syndrome, where we found 2 variants in the non-translated part of the gene in an intron. After exon 1, there's intron 1. And if you look at the splice machinery, you know that beyond the 5th nucleotide in intron, usually variants don't cause, have no functional impact. Well, in this case, a recessive condition, we didn't find any other disease mutation. And when you look at the whole intron, you see it's very small. And these 2 variants that we had here were actually not 2 kind of single nucleotide variants, but were a deletion of 12 nucleotides with recurrent sequences further on, reducing the size of the intron below a certain threshold and causing retention of the intron, and was a disease-causing mutation. So it is sometimes easy to know what the variant that we identify mean, but not rarely we have a real challenge to make sure that we can link what we see in the genome to the clinical picture in the affected individual. Again, from a different disease PKU, just to make you think that it's not always good to trust geneticists. This is a quality assessment scheme where we, for the last 20 years, check the genotyping and interpretation for a relatively straightforward condition called PKU. And the 20 to 30 labs that participate have to find mutations and interpret the variants that they find. And you can see here in the genotyping that even in the last years, there were some good years here, but even the last year, there were always one or two labs that either did not find a relevant mutation or found a mutation that wasn't there. Here, 9 labs, almost a third of the labs didn't find a deletion because they didn't use a complete method. Maybe even more disconcerting, many labs do not understand what they see. In PKU, you do not have just variants that knock out the gene completely, but you also have missense variants that cause impaired or reduced function, but doesn't cause a disease. And in 2007, 2012, we had a constellation where the genotype that people had to find was not PKU, but mild hyperphenylalaninemia, which does not require treatment. And about a quarter of the labs in this scheme, which actually found the variant, identified the genotype, didn't understand that that was not clinically relevant, did not interpret it correctly, and 3 labs actually offered prenatal diagnosis for what's effectively a normal genotype. So it has high levels of phenylalanine, but doesn't cause disease. So you need to be careful in how you interpret genetic data, and it's not all just automated analysis. One example now from EDS, from our own clinic. We saw a 30-year-old woman who had the genetic diagnosis of vascular EDS. Just to remind of you who are not familiar with vascular EDS, it's one of the most dramatic forms of EDS where you have extreme tissue fragility, you have perforation, rupture of arteries and organ, and you can have sudden vascular catastrophic events with an average life expectancy at around 50 years. So it's a really severe disease. You have specific clinical features. You can actually recognize it by this translucent skin. Hypermobility is only the small joints, is not the major feature. And this woman came to us because she wanted to know what she should do with the 2 children, because she knew that it's a dominant condition and she would have inherited, they would have a probability of 50% of having the vascular EDS as well. So if you ask the lady, what brought you to the genetic test in the first place? Well, she said, I have not many problems. I'm active sports person, but I had this prominent scar here after cesarean section, for which she required cosmetic surgery. And her mother had recurrent subluxations of the patella and the second toe. Apart from that, no evidence of connective tissue fragility. The examination was normal height, stature, face, no abnormalities in the skin apart from this large scar, and no hypermobility, maybe a little bit of hypermobility of the large joints, but certainly not the small joints. And the Baton score was not highly elevated, was elevated. So you could ask, why do you have the diagnosis when the clinical picture doesn't fit? Well, the lab that performed it did an Ehlers-Danlos panel, and that included the collagen 3 gene, and found this variant, and they were unsure what it meant, and there was some publication in a patient where this was reportedly pathogenic, so they reported it as a disease causing. A simple look into the databases shows that that an allele frequency of this variant was 0.16%, meaning that 1 in 300 of all Europeans have this variant as heterozygous carriers, and that alone indicates it's not a vascular EDS because it's too common for this. So again, the problem that one doesn't really think hard enough about the indication for a test. When one does a broad test, which includes lots of genes, and then you find variants, and you need label a family with a disease which is a disaster, as not a disaster, but really problematic. And you should be very careful when you do this lightly. Right, to come to an end with my presentation, most of the Ehlers-Danlos, the monogenic Ehlers-Danlos forms, which are summarized here, and I included the ABP1 as a classic-like EDS, so this is German, I apologize, are caused by single genes, and most are missense or single nucleotide variants that can be easily identified in the majority of cases with standard massive parallel sequencing, even carrier Sanger sequencing. One needs to make sure to keep in mind that collagen genes, variants in collagen genes that completely knock out the gene are generally less severe than missense variants that may have a dominant negative effect. And you should look at the question that you have to make sure that variants that you find that you're looking for to make a diagnosis are actually covered by your method. For example, there is a contiguous gene syndrome between congenital adrenal hyperplasia and hypermobility caused by loss of the J genes sub21B and TNX beta genes, which you only identify with adequate quantitative methods, or PLOD1, which is one of the kyphoscoliotic EDS genes. There is a common duplication, which is in 30% of, has a relative allele frequency of 30%. So you need to be really careful when you want to diagnose kyphoscoliotic EDS, that you, number one, make sure that you have good quantitative results to identify duplications, which are even more challenging than deletions, because you have 150% rather than 100% amount. And you might actually miss a missense variant on the other one, which is only in a third of the cases. In myopathic EDS, you again have the collagen problem with what does a mutation mean, because heterozygous missense variants may cause a dominant condition, whilst null mutations may cause a recessive disease. So if you find a null variant in a heterozygous state, you can't say, okay, I'm sure it's myopathic EDS because no, it's less severe and it should really cause disease or significant disease only in a biallelic constellation. And for example, in periodontal Ehlers-Danlos syndrome, you have specific missense variants that cause this particular condition, whilst null variants in a recessive condition cause a completely different disease, which is a systemic lupus erythematosus type of condition and has nothing to do with Ehlers-Danlos syndrome. So my last slide, we would normally use exome sequencing as our instrument approach to the diagnosis of Ehlers-Danlos syndrome. But we do not analyze an exome, but we look at those genes that are relevant. And we do not, that's a European approach, we do not want to target genes that are not clinically in question. For various reasons, for efficiency, but also for avoiding results that we don't know that they are requested and talked about. And we still have challenges with identifying variants and making sure that we really understand the link between what we see in the genetic results and in our patient. So essential is to have a good clinical characterization of the phenotype, to define questions and talk to the lab, and then you get a reliable result as an answer to your question, hopefully. So with this, I would like to thank you for your attention and hand over to Alessandro, who gives you a few interesting cases.
Okay, that's my turn. Can you see my slides? Okay, let's start. I selected 3 cases. My presentation is really mostly clinical with some genotypes, and I hope you can appreciate how these genotypes can help and are important to define the diagnosis and clinical and instrumental follow-up that follow the diagnosis. So just to remember, as Francisca already said, that Ehlers-Danlos syndromes are an heterogeneous group of rare multisystemic heritable connective tissue disorders characterized by a clinical triad of joint hypermobility, skin hyperextensibility, and tissue fragility friability. And in the last international classification in 2017 are listed 13 different subtypes of Ehlers-Danlos syndrome. Most of these subtypes have a known gene associated with. 3 major types are classical EDS, vascular Ehlers-Danlos syndrome. The most frequent one is hypermobile Ehlers-Danlos syndrome. Is unfortunately at this moment we still do not know which is the causative gene. Many types of Ehlers-Danlos syndrome show an autosomal dominant pattern of inheritance. Classical Ehlers-Danlos, vascular Ehlers-Danlos, hypermobile Ehlers-Danlos syndrome, and arthrochalasia Ehlers-Danlos syndrome, so also the periodontal Ehlers-Danlos syndrome. Some other types of Ehlers-Danlos show a autosomal recessive pattern of inheritance. This is the case for the classical-like subtype, for the cardiac valvular type associated with mutation in the collagen 1 gene. Some autosomal recessive mutation are the cause for the rarer types of Ehlers-Danlos syndrome, such as dermatosparaxis, kyphoscoliotic, brittle cornea syndrome, spondylodysplastic, and musculocontractular Ehlers-Danlos. And interestingly, some mutation in the collagen 12 alpha 1 gene are autosomal dominant in inheritance, mostly missense mutation in this gene. Some other mutation in this gene are autosomal recessive in inheritance, mostly, as Johannes already said, null mutations. Case 1, the subtitle that I chose was evolving diagnosis, from the commonest type of hypermobile EDS to one of the rarest. Let's show why. We saw in our outpatient clinic this patient in some years ago when this young female was 25 years old. The clinical examination was requested by a rheumatologist for chronic musculoskeletal pain with hypermobility and instability of joints. At birth, this young woman was birthed after cesarean section for podalic presentation. She presented with a right hip dysplasia and left hip subluxation. At birth was noticed also an hypertonia and congenital muscular torticollis that required a surgical treatment. In infancy, hypertonia went through an improvement, but the girl grew up with generalized joint hypermobility and motor clumsiness. In adolescent age and young adulthood, her phenotype was dominated by joint instability. She had 3 dislocation, patellar, and recurrent distortion, mostly at the ankles. She suffered by recurrent or chronic joint pain, hands, wrists, shoulders, ankles, knees, and spine. Recently, her phenotype was dominated also by chronic asthenia with post-exercise illness. She reported capillary and skin fragility and symptoms of orthostatic intolerance with recurring episodes of tachycardia and palpitations. She also had some recurrent occasional oropharyngeal dysphagia. Family history was unremarkable, apparently, because there was no parental consanguinity. The proband was not aware of similar feature in her parents, and so their parents did not receive a clinical examination at that time. It was 2012, yes. Then at clinical examination, when she was 25 years old, Baton score was 6 out of 9. So she had a generalized joint hypermobility. There was also distal hypermobility of interphalangeal and metacarpal phalangeal or metametarsal phalangeal joints. We noticed the lumbar hyperlordosis, kneecap strabism, flexible flat foot, valgism of the hallucis and knees, and at the temporomandibular joints, cleats and crepitus. The skin was soft, velvety, not hyperelastic. There were some post-surgical atrophic, but not papyraceous scars. Romberg sign was slightly positive, and we could still notice some mild limb hypertonia. Then, at that time, it was the 2012, hypermobile Ehlers-Danlos syndrome was diagnosed, and genetic test was not requested because Ehlers-Danlos syndrome does not have any gene associated to the date. So the girl went through a yearly follow-up until 2015 without relevant changes of our clinical phenotype. In 2017, new criteria were published for Ehlers-Danlos syndrome, for the hypermobile Ehlers-Danlos syndrome subtype. And we can see that this girl satisfied the first criterion for the hypermobile Ehlers-Danlos syndrome. She has generalized joint hypermobility. She had a multisystemic involvement of the connective tissue, and so the multisystemic score is satisfied. She has symptomatic joint hypermobility for pain and joint instability. But the hypermobile type of Ehlers-Danlos syndrome, today, we can do this diagnosis based on inclusive criteria, but we cannot forget that we also have exclusion criteria. So in this case, we can say, yes, there is an absence of unusual skin fragility, so we cannot think about classical Ehlers-Danlos syndrome or dermatosparaxis Ehlers-Danlos syndrome. She came to our attention from the rheumatologist, so the rheumatologist excluded rheumatologic conditions, but we recognize that this evaluation was not really completed. The girl had a phenotype that could be reminiscent also of neuromuscular disorder due to the congenital torticollis to the congenital hypotonia. Genetic testing was not performed to exclude other types of Ehlers-Danlos syndrome. So the diagnostic workup was not completed for that girl. So we re-examined this girl when she was 31 years old. So remembering of that clinical data at birth, we noticed that at her left thigh, she had a skin swelling in correspondence of the quadriceps. And also we requested an ultrasound examination of soft tissues. And this examination revealed a muscular herniation, where she had a muscular biopsy. So we did not record, in our record, add this muscular biopsy. So maybe the girl forgot to say us this, of this muscular biopsy. The muscular biopsy was negative in her results. In the last years, she had a worsening of her spinal pain. So we requested the spine magnetic resonance that showed a degenerative lumbar spinal osteoarthritis, okay, but also hypoatrophy with fatty infiltration of the multifidus lumbar muscles. We requested some examines for myopathies. Creatine kinase levels were normal. Electromyography of lower limbs showed mild signs of chronic neurogenic suffering, no myopathic changes. So we decided to go through a genetic test, requesting the sequencing of a multi-gene panel targeted to analyze all known genes associated with Ehlers-Danlos syndromes and overlapping myopathies. The result was an heterozygous variation in the gene encoding for the alpha-1 chain of the collagen 12. Is a G2A substitution at the nucleotide 8366. This nucleotide change is predicted to determine a missense variation at the protein level. So substitution of a glycine with an aspartic acid in the protein is a novel mutation. It's not reported in the literature. It is localized in the triple helical region of the protein, where there is the typical collagen structure of glycine XY repeating sequence, where X and Y are frequently proline and hydroxyproline. Interestingly, an identical amino acid change is known in close proximity with our mutation. This mutation has been already published in 2014 by Hicks and collaborators. The phenotypes in our work was defined as extracellular matrix-related myopathy with some feature reminiscent of Bethlehem myopathy. Parental segregation in our family is still ongoing. We think that maybe we can find this mutation in her mother because she was visited and showed the congenital contortionism, residual joint hypermobility, and some mild proximal and distal joint contractures. In the figure, you can see the repeating sequence in the polypeptide of the alpha-1 chain of the collagen 12 with the glycine followed by proline and another glycines followed by proline and proline. This side that I'm underlining is the actual site of the mutation in our family, and these other glycine, just 3 amino acids before, is that reported by Hicks in conjunction with a Bethlehem-like myopathy. So in the official Ehlers-Danlos classification is already present this subtype of Ehlers-Danlos syndrome that is called the myopathic Ehlers-Danlos syndrome, caused by mutation in the COL12A1 gene. So for this kind of Ehlers-Danlos syndrome, major and minor clinical criteria have been already published, and we can see in reported in green that our patient has congenital muscle hypertonia, muscle atrophy, proximal joint contraction where the congenital torticollis, hypermobility of distal joints she had. So we can conclude that she has a clinical phenotype that can be diagnosed as myopathic EDS, and we are waiting for the parental segregation to confirm this data by molecular testing. So take-home message is re-examination and going through more carefully through clinical records can help to make a more correct diagnosis. Second case, subtype is striking phenotypic variability. The index case in this family is a young female, 14 years old, last examination. At age 12, she was visited in another hospital because while doing physical activity in her gym, she had recurrent episodes of acute abdominal pain. So she went to the emergency room in a children's hospital. Abdominal ultrasound was negative, blood examination were negative, and abdominal angio-TC was requested and revealed an aneurysm of superior mesenteric and ileocholic arteries that requested an embolization. A clinical genetics examination was requested in that hospital. It's not mine. Were reported an history of congenital contortionism, joint hyperlaxity, a clinical examination generalized joint hypermobility, lumbar hyperlordosis with mild left lumbar gibbum. Skin was soft, velvety, easy bruising. No facial dysmorphisms were noticed. Echocardiography was normal, cranial angiomagnetic resonance was normal, the ophthalmological visit was normal, molecular genetics test, of course, was requested. Clinical geneticists in that hospital first requested the sequencing of a targeted multi-gene panel for congenital vascular anomalies, and this panel was negative. And then, in second instance, they requested the sequencing of genes associated, linked to hereditary connective tissue disorders with vascular fragility. And this was positive. This test, this last test turned positive. Turned positive for not in the gene associated with vascular ADS. Maybe some of you, also me, could think about this hypothesis. She is heterozygous for a known mutation in the pro-alpha-1 chain of the collagen 1. This is a known rare pathogenic variant already reported in some Ehlers-Danlos syndrome families. Parental segregation was requested, and this study demonstrated a maternal transmission. It means that the mother, who is 52 years old, is heterozygous for the same variation. So this mother asked me a consultation. But before, let's say that collagen 1, as Johannes Zschocke already said, is mainly known as the gene causative for osteogenesis imperfecta. But the two genes that are causative for osteogenesis imperfecta, encoding the pro-alpha-1 and pro-alpha-2 chains of the collagen 1, are a perfect example of allelic series. So different mutation in the same genes can cause different phenotypes. The same genes can cause Cafe disease, can cause in the spectrum of Ehlers-Danlos syndrome the arthrochalasia type, that is autosomal dominant in inheritance, can cause the cardiac valvular type with autosomal recessive inheritance. And we also have this specific mutation, the arginine 312 cysteine mutation, that has been linked both to the classical type of Ehlers-Danlos syndrome and to the vascular type of Ehlers-Danlos syndrome. So a kind of strange example of a same mutation that bridges together two different subtypes of Ehlers-Danlos syndrome. Going back to our family, the mother had a childhood history uneventful, except for 2 febrile seizures. She had 2 pregnancies, and here we can notice something that is reminiscent of the Ehlers-Danlos phenotypic spectrum. The first vaginal delivery was complicated by vaginal lacerations. There was also a poor response to epidural analgesia. In the puerperium, she had an episode of varicophalmitis. The second pregnancy was complicated by threats of abortion and early membrane rupture. His skin had easy bruising. In the past, she received also physiatric assessment for joint instability that was symptomatic, especially for recurrent sprains and recurrent musculoskeletal pain at right hip, lower limbs. She had a recurrent enthesopathy at the Achilles tendon, at wrists, at elbows, and she received a prescription for insults. IV that was normal. Vascular study was negative for aneurysms and dissections. Echocardiography was negative. So in conclusion, another slide. Clinical examination showed generalized joint hypermobility, skin hyperextensibility, more than 2 centimeters at the dorsum of the hands, more than 3 centimeters at neck and elbows, and some atrophic scars, mildly papyraceous, not hemosiderotic. In conclusion, we tried to apply to this mother and daughter the vascular Ehlers-Danlos syndrome. And we can see that, yes, the daughter, we can say that she respects vascular Ehlers-Danlos syndrome criteria because not really an arterial rupture, but an aneurysm with a really initial dissection of the mesenteric artery. The mother has really a few signs of vascular Ehlers-Danlos syndrome. We can say that among the major criteria for the vascular Ehlers-Danlos syndrome, she had just the mild perineum tears as a complication of the first vaginal delivery. And coming to the classical Ehlers-Danlos diagnosis criteria, on the opposite side, the mother fully respects the clinical criteria for classical EDS, for skin hyperextensibility and atrophic scarring, that is mandatory for this diagnosis, and for joint hypermobility. But the daughter does not. She had not skin hyperextensibility and atrophic scarring was mandatory. So just to remember the striking bridge and the striking clinical variability that a same mutation can have also within the same family. Case 3 it's a case of a difficult nosological classification after test. So the test, we think, confirmed in our patient the diagnosis of a hereditary connective tissue disorder. But in this case, there is a phenotypic overlap with another hereditary connective tissue disorder that is not Ehlers-Danlos syndrome. Let's show. The index case is a male. At last examination, he was 60 years old. His first clinical genetic examination was when he was 56 years old. His birth and first infancy was uneventful, except for right cryptorchidisms, treated later at age 11. At scholar age, he received orthopedic evaluations for flexible flat foot, for joint laxity. She wore orthopedic shoes and insoles. He felt himself as double jointed. Hypermobility was complicated by joint instability. He suffered by recurrent dislocations of the left elbow, leading to a fixed subluxation, and he also suffered by ankle sprains. Hypermobility was also complicated by pain, recurrent spine and knees, and striking was the history of acute lesions. At 15 years old, he had an injury of the ligaments of left knee. At 21, an Achilles tendon rupture. At 23, a rupture of the right rectus femoris. At 15 years, he had an injury of the ligaments of the right knee, and a rupture of the left rectus femoris. He also had other surgical history for left varicocele at 26. He also was operated for a testicular tumor at 31. He received surgery for cholecystectomy, and this last surgery was complicated by the intestinal perforation. So many aspects that are reminiscent of the tissue fragility that is typical of Ehlers-Danlos syndrome. Genetic examination was requested when he was 56 years old for tissue fragility and joint hypermobility. At clinical examination, he had a Baton score of 5 out of 9, corresponding to generalized joint hypermobility. There was also distal joint hypermobility and the fixed subluxation of the left elbow that you can see in the figure. Flat, flexible foot was noticed along with a pectus excavatum. The skin was soft, hyperextensible, more than 2 centimeters at the dorsum of the hands. There were some mildly atrophic surgical scars, and strikingly, he had this intensely blue sclera with the microcornea, right more than left, bilateral arcus senilis, and residual decimitoceal at right eye, as depicted by the white arrow in the figure. The blue sclera are actually a dominant trait in this family, as you can see in this version of his pedigree. So necessary autosomal dominant, this trait inherited from the mother. There are few records about his relative. He cannot say if the mother was hypermobile. For sure, neither the mother nor his grandfather had recurrent fractures. We visited her daughter when she was 15 years old. She had mild hypermobility, Baton score 3 out of 9, but normal sclera, normal skin. So the clinical diagnosis for the daughter was not affected. Just to go through our first hypothesis, remembering that two among the rarer subtypes of Ehlers-Danlos syndrome can have blue sclera among their clinical criteria, the brittle cornea syndrome. So we requested the corneal pachymetry measurement of the thickness of the cornea, but this was normal. Another hypothesis was the kyphoscoliotic type of Ehlers-Danlos syndrome. So the genetic test was requested. No mutation were found in the gene associated with brittle cornea syndrome and kyphoscoliotic Ehlers-Danlos syndrome. So these two forms were definitely excluded. The multi-gene panel sequencing instead revealed an heterozygous mutation in the pro-alpha-1 chain of collagen 1. Is a glycine substitution in the triple helix of this collagen. Is a known mutation because previously reported in an Italian patient classified as affected by osteogenesis imperfecta type 1. Actually, in this paper, is not available a clinical description of this patient. The mutation was absent in the clinically unaffected daughter, thus confirming that she was not affected as the father. This is an interesting mutation because it's a missense change that fall near the pro-collagen and protein cleavage site of the pro-alpha-1 chain of collagen 1, and the other mutation in this site, both in the COL1A1 gene and the COL1A2 gene, have been already described in patients with a clinical phenotype characterized by a clinical overlap between Ehlers-Danlos syndrome and osteogenesis imperfecta. Francisca Malfait knows very well this argument because she published the more important series of patients with showing this overlap. And she hypothesized that this kind of mutation can lead to this kind of clinical overlap. Among osteogenesis imperfecta types, we can for sure exclude the perinatally lethal osteogenesis imperfecta. The previous in the previous nosology, this kind of osteogenesis imperfecta is known as type 2. We can exclude the progressively deforming osteogenesis imperfecta, but we can also exclude the common variable osteogenesis imperfecta, previously known as type 4 osteogenesis imperfecta, because this patient, our patient, had not multiple fracture, and this kind of osteogenesis imperfecta had the normal sclera. Sclera are blue in the classic non-deforming osteogenesis imperfecta. Usually, these patients have recurrent fractures. So, in the osteogenesis imperfecta spectrum, we cannot definitely exclude this diagnosis, but the absence of fractures, the clinical phenotype dominated by hypermobility and tissue fragility, like in Ehlers-Danlos syndromes, pushed us to consider that the correct diagnosis could not be osteogenesis imperfecta, and maybe something new in the spectrum of Ehlers-Danlos syndrome. Francisca Malfait published, as I already said before, this important paper reporting some patients in whom an heterozygous mutation in the pro-alpha-1 collagen 1 affecting the processing of the aminopropeptide result in overlap syndrome between osteogenesis imperfecta and Ehlers-Danlos syndrome. In the last year, a novel OMIM entry was created for this kind of overlap. In OMIM, this overlap syndrome has been called combined osteogenesis imperfecta and Ehlers-Danlos syndrome. We've recently published, the first name Silvia Morlino, last name Marco Castori, our series of patients that we feel can be classified in this overlap. Marco Castori preferred to propose a neutral term of collagen 1 related overlap disorder. So work in progress. Maybe in the future we can see this last a novel entry in the nosology of Ehlers-Danlos syndrome. I cannot say this. The international consortium on Ehlers-Danlos syndrome maybe in the future collecting new data, new biological data, new functional data about this mutation can solve this question. And so just to summarize my last two presentations, the series, the allelic series linked to mutation in the collagen 1 genes can be expanded to include the bridging phenotype between vascular and classic Ehlers-Danlos syndrome caused by the specific arginine 312 cysteine mutation in the COL1A1 gene, and maybe in the future also the so-called osteogenesis imperfecta Ehlers-Danlos syndrome overlap. Thank you for your attention. Open discussion.
I remind to the participant that they can ask to the speakers anything by the questions and answers at the bottom of the Zoom platform, or by chat, or by raising their hand. There is no question. Would you like to comment, Francisca, some of this presentation?
Yes, thank you, Alessandro, for the very interesting case presentations. Actually, for your first presentation on the patient with a type 12 collagen mutation, we also have here in Ghent a few examples of people who were first clinically diagnosed as hypermobile EDS before we knew that type 12 collagen was associated with this rare type of EDS. And then afterwards, when we did then genetic analysis, that we did find a mutation in type 12 collagen. So these are very rare, but especially if there is this history, I think of like torticollis. We also saw that in a few of our patients, torticollis and congenital problems such as dislocation or scoliosis should ring a bell. Although there are not so many in the patients that I have seen, there's not so many distinguishing clinical features actually that really hint towards a type 12 collagen mutation. So it's, as far as I mean, based on the patients that we have seen so far, not a very easy diagnosis to make. So it's a very interesting case, I think. Yeah. I don't know, Johannes, whether you have seen type 12 collagen patients at your service so far.
Not myself, no.
No.
There's a question on the questions and answers section. Could you read it? For the OE EDS overlap, are the variants in COL1A1 all missense? Is COL1A2 involved?
You want me to answer? Okay.
Okay.
So in the publication that, at least from what I know by heart, in our publication, the one that I was the first author of, we had a few patients, if I remember correctly, with a single exon skip. So it's certainly not only missense mutations, but quite striking is that most of these mutations, although not all, are near the amino proteinase cleavage site. So that's the more striking feature. So, but it's not only missense, it's also exon skips. And we also had a few in the COL1A2 gene. So it's not only COL1A1. Yeah.
Actually, to add on this, all the exon skips were in COL1A2, I think, in your publication.
That is possible, yeah, but I don't know by heart
No.
in publications, but that's possible, yeah. Thanks.
We also had some COL1A2 mutations.
Yeah.
And Francisca, you remember very well.
Okay, I think we can stop with the webinar. There are no, oh, sorry. There is a, okay. Thank you. Excellent presentation from Linnea Baldwin. Okay.
Thanks.
Okay, we can stop this webinar. Thank you very much to Professor Zschocke and to Dr. Ferraris, and also to Professor Malfait for her availability. And thank you so much for your presentation, your webinar, and see you in the next EDS webinar, of course.
Okay, thanks a lot.
Bye.
Bye-bye.
Bye-bye.